volume of immunocompromised individuals in our country continues to rise. And unfortunately, these individuals are susceptible to infection, pneumonitis, and a variety of other side effects due to these medications and treatments. And frequently they will present ill with acute and subacute pulmonary infiltrates, which are investigated by bronchoscopy. My name is Michael Bourne. I was a pulmonary and critical care fellow at Mayo Clinic, Rochester from 2016 to 2019. I'm currently a staff physician at the Oregon Clinic Pulmonary West in Portland, Oregon. The title of our article is Utility of Transbronchial Biopsy in the Immunocompromised Host with New Pulmonary Radiographic Abnormalities, and it will be appearing in the June issue of Mayo Clinic Proceedings. There's been a good amount of work done to identify the role of bronchoscopy in this patient population. There's also been work done, especially in the stem cell transplant population and hematopoietic cancer population, to see what the role of a transbronchial biopsy as well as a bronchoalveolar lavage would be. Little or no work has been done in immunocompromised patients as a whole. Our paper aims to identify the role of transbronchial biopsy in this population that present with acute and subacute pulmonary infiltrates. Using the bronchoscopy database in the Division of Pulmonary and Critical Care Medicine at Mayo Clinic, Rochester, we investigated all bronchoscopies between 2012 and 2017, and we identified 192 patients who were immunocompromised as designated by the physician's choice of the bronchoalveolar lavage immunocompromised host panel, who underwent concurrent bronchoalveolar lavage with transbronchial biopsy. Our primary aim was to assess how often the unique positive findings from the transbronchial biopsy, apart from all other concurrent biopsy and inspection methods, justified changes in management in these immunocompromised patients. We divided these 192 immunocompromised patients into 6 subgroups. Patients who were on immunosuppressive medications for whatever reason, solid organ transplant recipients, hematologic cancer patients, patients with a solid tumor on active immunosuppressive chemotherapy, and stem cell transplant patients. After dividing those groups, we meticulously went through the clinical record to look at justification for the procedure and the outcomes of the bronchoalveolar lavage compared with the transbronchial biopsy. And then we looked at the clinical notes after the procedure to see what changes in management were distinctly justified and explicitly stated in the clinical notes to be due solely to the transbronchial biopsy. What we identified as a change in management there were several things. One of them was a change in steroid, change in chemotherapy, change in immunosuppressive agents, the decision to change the goals of care, and the decision to pursue an additional procedure. What we found after reviewing the clinical notes among all these subgroups is that among all comers, all 192 patients, 28% of these patients had management changes justified solely by the result of the transbronchial biopsy. There were obviously more management changes based on results of the bronchoalveolar lavage, but 28% of these patients had management changes that could not be justified by what was found on the bronchoalveolar lavage, only what was found on the transbronchoscopic biopsy. When you break it down into subgroups, things get a little more interesting. Some groups have a higher yield than others. For instance, we found that solid malignant neoplasms that are on active chemotherapy, active immunosuppressive treatments, which included immunotherapy, had their management changed 62% of the time. So we identified a subgroup that had a dramatically higher rate of clinical management changes justified by the results from the transbronchial biopsy. But as a whole, this group, about 1 in 4, would actually change management. About 60% of the time, something else was identified on the transbronchial biopsy. So the yield was good. It just didn't always translate into a meaningful change in management, except in the solid tumor group that was on active chemotherapy. Now, our counterbalance to this whole thing is safety and complications. There's been a lot of work done in the utility of transbronchial biopsy in the immunocompromised subset of hematopoietic stem cell transplant patients. And this shows that that group is very high risk for complications, including bleeding, pneumothorax, iatrogenesis in general. We found similar rates of complications that you can find elsewhere in the literature. Among all comers, about 14% of these patients undergoing a bronchoalveolar lavage plus a transbronchial biopsy experienced a complication. One reason that's frequently cited for wanting to pursue transbronchial biopsy in the immunocompromised patient is the fear of invasive fungal infection. What we found was interesting in that not a single fungal infection was identified on the transbronchial biopsy that was accounted for on the bronchoalveolar lavage. And roughly only about half the time was that fungal infection identified on transbronchial biopsy, meaning that in our cohort of patients, the transbronchial biopsy offered zero benefit in identifying patients with invasive fungal infections. So in summary, what we found was that transbronchial biopsy can be a useful adjunct in the right clinical context. We found that especially in patients who are immunocompromised secondary to having a solid malignancy, who are undergoing active immunosuppressive treatment, do tend to have management changes justified by the unique results identified on the transbronchial biopsy. The most common thing identified on the transbronchial biopsy in all comers, and especially in the solid malignancy group, was organizing pneumonia. We generally find that a bronchoalveolar lavage is more useful in ruling out infectious etiologies, and a transbronchial biopsy is far more useful to identify non-infectious pulmonary infiltrates. Cancer recurrence was a common entity that very much favors transbronchial biopsy. Among the solid tumor group, sometimes cancer recurrence was identified as a cause of these new pulmonary infiltrates. Only about half the time was the cancer recurrence identified on BAL cytology. And so the transbronchial biopsy is certainly much more sensitive for identifying this. I would invite you to read our article. It will help you in your care of the immunocompromised patient with acute and subacute pulmonary infiltrates by helping you and consulting physicians select the ideal diagnostic procedure.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.